Good afternoon, everyone, and welcome to this week's National Bleeding Disorders Foundation, formerly National Hemophilia Foundation, Wednesday webinar. My name is Fiona Robinson, and I am the series host. In today's webinar, we will learn about setting the Health Equity, Diversity, and Inclusion, or HEDI, agenda for the National Bleeding Disorders Foundation. This webinar is being recorded and will be available to the community on the NBDF website shortly after the webinar. We encourage you to ask any questions you may have today. You can ask your question by using the Q&A feature at the bottom of your screen at any time during the webinar. We will monitor these questions, and following our speakers' presentations, we will put your questions to them. Today, we're joined by Dr. Carrie Norris, Vice President of Health, Equity, Diversity, and Inclusion at the National Bleeding Disorders Foundation, and by Karina Lopez and Marissa Melton, who are both NBDF HEDI program specialists. I'd like to thank Carrie, Karina, and Marissa for joining us today, and I will turn things over now to Carrie to get us started.
Thank you, Fiona, for that wonderful introduction. So today we're going to share a little bit about how we came up with this 10-year strategic plan or strategic direction, right, for how to approach health equity, diversity, and inclusion for the bleeding disorders community. Next slide. So first, let us take a look at our mission overall. So I'm sure you've seen this hundreds or thousands of times, but to just highlight why our particular portion is so important, we want to look at that very last part of the actual mission statement where it says enabling people and families to thrive. In order to do that, then our organization, along with our strategic partners, can only reach optimal health for the community as a whole and for individuals by addressing health disparities, addressing issues around diversity, equity, and inclusion, and making sure that we put each and every individual and all families and all caregivers, stakeholders, and etc., the opportunity to be able to thrive in the environment, the opportunity to reach their optimal health outcome, the opportunity to get to health equity. Next slide. So in order to talk about how we got to this point, you just don't pull a 10-year plan out the air, right? So we started out early. I came to NBDF in 2021 and just fell in love with the community and began to try to understand everything that was going on in the community. But in order to understand that, I had to do what? Go to the community, get together with multiple stakeholders and gather information. And so that's what I did. So our background efforts in order to create this strategic direction occurred in various stages. And so the first thing that we did was we held a Health Equity Summit in 2022 in Atlanta. And there we had breakout groups that particularly focused on access, policy and payer systems, mental health, and health system navigation. And in those small groups, our stakeholders, which consisted of lived experience experts, NBDF staff and officers, and senior leadership team. It consisted of industry, healthcare providers, and also caregivers. And we began to kind of suss out what was going on in each of these four areas and see what are some of the barriers that are in place for various members of our community and what can we do for those barriers. So it just wasn't, let's talk about all of the problems. It was very solution oriented, right? So you can state what the barrier is, but let's talk about what the evidence is to address that barrier, or what the promising practice is that's currently in place that seemingly works, but needs a little bit more science and evidence behind it. So from that, then we had health equity graphics that came out. So these are visual representations of what the schema looks like for addressing health equity, diversity, and inclusion in the bleeding and blood disorders community. And through that, then we were able to look at barriers to care, barriers to access, barriers to quality care and treatment. And that afforded us the beginning of collaborative partnerships that allowed us to look at the landscape and do what we call a landscape analysis of all of the issues and what every organization had kind of gathered from the landscape of health equity, diversity, and inclusion within the bleeding disorders community. From the Health Equity Task Force, we included stakeholders who self-selected as members of our Health Equity Task Force that took these barriers and continued to work away and kind of chip away at them, right? And work towards change. And then, of course, in 2023, we had community roundtables which were held in Florida, in Colorado, and also we had virtual roundtables as well. And we had one big roundtable at BDC on last year. So we gathered additional information there, input from stakeholders, input from chapter leaders and chapter directors. And then we formed small groups. And so these were informed interactions with NYLI persons. Education team has small groups that we met with. We continue to work with various chapters throughout the country and provide technical assistance on their health equity efforts. We also learned a lot from our interaction and our play into the overall schema for the National Research Blueprint. Attending other conferences, and of course, collaborations led to our continued learning of what health equity, diversity, and inclusion looks like for our community. And after putting all of that together, we were able to complete and formulate what's called the E3 model, which E3 stands for engaging, empowering, and elevating. And so that comes later. That's the second stage of this. But this is how we got together to look at how every hour, every day, we're working towards health equity, diversity, and inclusion. Next slide. So as you remember, when we were at the summit, we held roundtables and we also had talks with various stakeholders in the community. We talked about what health equity looks like and what we want it to look like when we reach the stage where people and families are thriving. And so as we look at that, then we know that in order to do health equity properly, you have to meet people in communities where they are. You have to remove those barriers and then ensure the inclusion of all stakeholders. So in the first picture, you'll see that, everybody's watching the soccer game, right? I'm sure you've seen this model elsewhere, but we were able to adjust it from baseball to something more international like soccer so that everyone can relate, because we know that bleeding disorders affect people all across the globe. And so as the people are trying to watch the game, you see that everybody can't see over the fence or barely can see over the fence. And so equality looks at we give everyone the same resources and hope that they work it out. Well, that's not good enough. And that's not what we're doing here at NBDF. So we move towards health equity by actually taking the barriers that we've learned about over time and beginning to label the planks on the fence as barriers. Because what are fences? They're barriers. And so in order for us to reach this social justice, this health justice, it's important for us to knock down those barriers. But before doing that, we have to make sure that we give people access. So that's meeting communities where they are. So as you can see, each person gets the type of support that they need to be able to at least see over the fence, to be able to see the game. But that's not enough. So we then look at those social determinants of health, which are labeled on the fence, which are connected to those barriers that are in place that keep people from accessing adequate care and treatments and getting their hands on services and resources that they need to thrive in this community. So we labeled the fence and then we move towards knocking it down. And that's by using the E3 model to be able to address health equity issues and barriers at the individual, the community, the organizational, and institutional level due to your capacity. So you're not asked to stretch beyond what you are able to do or to stretch yourself, beyond being able to address your own individual biases. So in order to get to justice, we knock the fence down. And that's what we're doing here at NBDF with this strategic direction that we're giving for work and health equity. So the fence is knocked down. Everyone still has access according to what their needs are. And that step leads us to soon they won't just be watching the game, they'll be included in the game. They can play if they want to. Next slide. So our pathway forward looks at those proximal indicators and those distal indicators that are listed on the fence, right? Those are the things that you either can or cannot intervene on, right? So proximal factors are those factors that are closest to us that we have the greatest influence on. And then those distal factors are things that are a little more further removed from us. We don't have direct influence, but if we work collaboratively with others, then we can definitely make a change with those distal factors. And then the last column that you see is the actual E3 at work and what it looks like. So really quickly, if we're talking about mental health and coping as a proximal factor. So what's going on with people's mental health actually affects their physical health. But we also know that in those distal factors that there are inequities and there's a lack of community resources that are at the table for people to be able to cope and deal with mental health issues. And then there are also injustices that are occurring in communities that also affect people's mental health, therefore their physical health. And so action items or the E3 model would say these are the various ways that you can intervene. This is not a comprehensive list, but we're working on that. So examples of that would be the mental health first aid, education for social workers and therapists on bleeding disorders, mental health resources, and then also diversifying the field of social work and also the field of psychotherapy so that persons are, dealing with cultural humility. They're dealing with people who look like themselves. They're more comfortable and they're more likely to use the services that are available to them. In order to do this work, then we must acknowledge limitations that occur within policy, people, and politics. So we don't forget that we have to work inside of systems that currently exist. Next slide.
Thank you, Carrie, for that wonderful introduction and background. So as a culmination of all of this information that we've spent as a team the last couple of years gaining and learning from community members, and then also through research of other rare disease groups, we have been able to identify priority populations that we will be focusing on as part of this 10-year plan. The first is bilingual and multilingual populations, minoritized and marginalized populations, rural residents, and those who are geographically isolated, women and girls, and people who have or had the potential to menstruate, and young adults. So these are, again, the 5 kind of focus areas and populations that as a team, and then again, NBDF as a whole will be focusing on through our work for the next 10 years. Next slide, please. So the first population that I'll be speaking about are the bilingual and multilingual populations. So as a group, well, we know as the United States, there are, excuse me, tons of most people who speak English. However, there are a number of those who speak either a second language or, this second language, an additional language as their first language. So Spanish reaches or is spoken by 41.3 million people, Chinese as the third spoken language within the US. This is all according to the US Census Bureau. So based on this information, we are able to understand that there's a greater need to have more resources in additional languages, as well as access to translators, access, as Carrie mentioned earlier, to physicians and providers who look like them or speak like them. So this will be a population that we are focusing on in addition to these other ones that I'll be listing next. Next slide, please. So talking about minoritized and marginalized populations, these are persons who have traditionally been underserved or excluded, and or oppressed based on given social standing or some characteristic. These are included but not limited to race, ethnicity, sex, gender identity, sexuality, age, income, disability or ability, language, culture, faith, geographic location, or country of birth. This is a pretty exhaustive list, but again, it's covering many populations that have historically not been served through healthcare. And we now want to specifically focus on them, especially in this intersection of those who live with a bleeding disorder, and making sure to meet them, again, as we've said, where they are with needs and resources specific to them. Additionally, we want to thank the working group to help us provide this definition that can be used by all. Next slide, please. Our third population or group that we'll be focusing on are rural residents or those who are geographically challenged. So within the US, there are 46 million Americans, about 15%, who live in rural areas as defined by the Census Bureau. Those who live in rural areas are unfortunately more likely to die from heart disease, cancer, unintentional injury, chronic lower respiratory disease, and stroke than their urban counterparts. So this really hits at that due to their geographical isolation, access to healthcare for treatment for chronic disease is often lower or is not as comprehensive. So in general, those who live in rural areas often tend to be older and sicker than their urban counterparts. So this is an area we want to be focusing on and recommend getting actually out to these residents. This is a challenge for them to get into cities in these areas for treatment. So getting to them, meeting them where they are at, and hearing truly the issues that are specifically affecting them as rural residents. Next slide, please. Our fourth population that we will be focusing on are women, girls, and people who have or had the potential to menstruate. This is a comprehensive term that is inclusive of all persons who have experiences and specific needs as people who were assigned female at birth. So now, regardless of their gender identity and how they identify now, that potential is the unifying element here, the potential to menstruate or previously had the potential to menstruate. So we understand that persons who fall under this group are underserved, traditionally underserved, or are underdiagnosed, So as many as 1% of women, girls, and other people have with the potential to menstruate within the US have a bleeding disorder, but are unaware of their condition. That's about 1.6 million women or girls. So we, as a team, but also as an organization, understand the importance of education, providing resources, comprehensive healthcare to persons within this community and population. Next slide, please. And finally, our fifth population that we recognize needs to be focused on are young adults. So 25.1 million persons, 21.5 million persons identify themselves as young adults within the US. A percentage of these persons do have a bleeding disorder. So of course, that is a main focus for us. But additionally, that age of transitioning into adulthood has been named a barrier to care for folks within this age group. So this means transitioning to adulthood, identifying new insurance plans, identifying new hematologists when they move either for college or just for life changes. Once they fall under, or off of their parents' insurance, it can be very difficult to navigate the health system as persons who haven't been able to do that before. So it is important to identify and work with folks in this category or this population, to help support them, again, providing resources and education. Next slide, please.
Thank you, Marissa. So now that we have heard the HEDI efforts explained by Carrie and the priority populations explained by Marissa, now we go into the how, right? So these are our top 10 strategic approaches for the next 10 years that are going to help us address the priority populations, the barriers that we have heard loud and clear from community members. While this is an extensive list. I will not go over each and every one of them, but I want to make sure I highlight a couple of them. For example, number one, increasing access to care for all. We know that access to care is a huge barrier for our bleeding and blood disorders community, and we want to make sure that we address the barriers to help them reach their optimal care, right? Thus enabling people and families to thrive. Number two, translation into the patient's primary language. We know this is in conjunction with the bilingual and multilingual need that Marissa mentioned. We want to make sure that we're translating into the patient's primary language that they can read and understand. This is resources that are forward-facing, right? We want to make sure that we are engaging those populations that are probably not engaging because they're like, okay, well, why go to a conference or hear a seminar if they are not speaking in the language that I necessarily understand, which ties into number three, right? Engaging the unengaged populations, again, rural residents or geographically challenged populations. Number four, health and literacy or plain language use. When we go out to meet, let's say, like the geographically challenged populations, we want to make sure that we are speaking not in scientific medical terms, but as we should be on a 7th to 8th grade reading level that people can understand, given the low rates of literacy. When we think of access to mental health services and programs, how do we bridge the gap, right? And in addressing, like in providing safe spaces and addressing the psychosocial toll that a bleeding disorders takes on our community members and providing culturally appropriate treatment options. I want to make sure I address number 10, addressing policy needs for bleeding disorders community. Our public policy and access team does an amazing job in advocating for our community, and we work alongside them to ensure that we increase the diverse representation of people who, of community members who go to Washington Days or their state advocacy days. We want to make sure that we equip them with the necessary tools, resources to empower them to self-advocate and to share their story, because we know how important it is and how impactful it is for them to share their story. And I want to make sure I know also that these strategic approaches are based on the capacity of the stakeholders, right? We do not want to be prescriptive. This is these should be addressed with the resources that are available to the stakeholder that is necessarily working on addressing these barriers and reaching health equity, diversity, and inclusion. So the next slide here, these are additional HEDI strategic approaches, and while they are not top 10, we do want to note that a lot of these approaches are already being implemented, but they can definitely be scaled up. So for example, building HEDI champions at every level. We currently have HEDI champions at NBDF that we equip with the necessary resources and tools to empower them in the DEI work and ensure that they're using the HEDI lens in their everyday work, right? But we want to make sure that we take it a step beyond. How do we identify champions that are currently in our community members, whether that's chapter staff, healthcare providers, lived experience experts, right? I know the NRB is also having like their own champion as well. So it's taking it to that next level. Again, translation of scientific findings. Are we making sure that we're translating these into plain language that is understanding to the community members, and making sure that is the information that we're translating is culturally and linguistically appropriate. Addressing social determinants of health, right? Using the E3 model. We've heard loud and clear the many barriers that our community members have made a note of, but we want to make sure that we address them to kind of fulfill NBDF's mission, right, of enabling people and families to thrive, but also reaching our health equity, diversity, and inclusion for everyone. With that being said, this is our contact information should you want to reach out to us, but I will definitely now open up the floor for Q&A. Thank you.
Super. Thank you very much, Carrie, Marissa, and Karina, for that really interesting and inspiring presentation. It's a lot of work and a lot of input that's reflected here, and really exciting to see what you've done and where you're going with all of this. So we'll go ahead now with our live Q&A. If you have a question for Carrie, Marissa, or Karina, please enter it in the Q&A feature at the bottom of your screen, and we will do our best to answer all of your questions. One question that I had, maybe I could just ask you to think about and expand upon. We often hear the idea of meeting people where they are. And I guess that could mean a lot of different things, but is that something you can expand on a little bit? Because I think that can be interpreted in a whole lot of different ways. And I'm interested to hear what that means to you, how you envision that.
So I'll start, and Karina and Marissa, feel free to jump in and add to. But an example is if we are working in rural Alabama versus metropolitan New York, you won't have the same types of population. You won't have the same socioeconomic status, education level, or access because of the structural representation and whether or not people are rural, metropolitan, et cetera, et cetera. And then we do know that, some cities have HTCs, others don't. They have to travel long distances, things of that nature. So when we say meet people where they are, we have to consider geographically where they are, educationally where they are, their understanding as far as insurance coverage and knowing that lingo for insurance and what's covered and not covered. We also have to look at how well they understand their disease, how well they know healthcare providers, and how well they understand the system. And we work to meet them where they are. So whether it's a low literacy person or a person that, is, quite educated and knows everything, but still needs help in navigating certain systems or certain environments, then they tell us what the need is and we meet them there. So it's very individualized and also based on individual communities and what communities look like and what those communities need. And as you know, it varies and it looks very different across the United States as far as access is concerned, but it's extremely important. And that's the only way to be able to get this work done.
I would just tack on to that. Carrie mentioned language and literacy, but that includes, tailoring services in different languages. When you're going to events, having an option to have a presentation in both English and Spanish, if that is the second primary language of the community that lives there and is being served by this event. That could also look like having an in-house translator to use the headsets, different opportunities like that. And I would even also loop in, children and the events that you would have for parents of bleeding disorders versus, the young teens or preteens would be a lot different. So just making sure that everything that we're doing, education and advocacy wise, is true to the community that is there, because across the US, it's not a one size fits all for everyone within the bleeding disorders community.
Right. Yeah. I guess it means a lot of things, doesn't it? Where people are is really quite a diverse set of factors. We have a question for somebody who is asking if they're, let's say, in a chapter that has very limited staff, like let's say they're 1.5 staff, and they see this as really important work, but they don't know how to tackle it. How would you even start? I mean, they don't want to leave anybody out, but it's a bit overwhelming, excuse me, with very limited resources to try and take this on. How would you advise them?
It can be intimidating, and that's perfectly okay. They can, of course, reach out to us so we can help them to create an individualized plan of moving forward. But the base thing is taking a look at the community that you serve and really surveying to see who's at the table, who's missing from the table, and how to engage those folks, right? And then doing simple things to get them engaged with events, which you're probably already having, but extending the welcome, making it warmer so that, or challenging them, each one reach one, right? So everybody brings someone with them to these events, and then you expand your reach. You can also do things like translating into languages. You have apps, you have things on Google that are helpful for that. And then my team here can help with that as well. In addition to small things like surveying, again, what organizations are in your parameter or within your geographic location, partner with them to supplement some of the services that are needed, right? So let's say there's a family and they have multiple affected children. However, the father loses his job, and then the family is kind of like in this state of flux and trying to figure out how to afford things. And then you have competing interests. Do we pay the light bill or do we buy factor, right? Do we pay our co-insurance or, do we pay our mortgage? Things of that nature. So there are systems in place. There are services, of course, in place. They can contact their social worker at their HTC to help them to get these connections with these community orgs. There are workforce development programs that will help family members either gain a new skill set or pivot to a different job or what have you. So there are multiple ways to do the small things and small steps. And where you don't have the financial resources, partnership always works, and you can leverage the financial resources that belong to the other organization.
Great. Yeah. With respect to the languages, I thought it was really interesting to see the statistics about what the top 5 languages are in the US. I'm in Canada, so I'm always like, oh, look, French is down, not even in the top 5. But it raises, I think, an interesting question. I know NBDF has resources in Spanish. What about the other languages in that top 5? And are there financial resources available if somebody identifies the need for translation that resources are not available in, but maybe they are finding they need to do that? Because, there is a certain cost involved in translating, especially medical and scientific content. It takes a pretty specialized resource to do that.
Absolutely. So there are organizations that our education team partners with to be able to provide those specific services or to connect chapters with those organizations. And then we also have chapters who do have those multiple languages. So sometimes you just have to talk to the people that are within your chapter service. If you are in Pennsylvania and you find that you need, to add a language that no one in your immediate circle has or has access to, and it's beyond our in-house English, Spanish translation at this time, then you might be able to reach out to someone in Southern California that has a more diverse population, or someone in New York, or someone in Louisiana who have more diverse populations, and then they might have that already translated, or they might have actual resources that they can just share with you and allow you to adapt those particular resources to your community for what your needs are. And then, of course, there's always, free things like Google Translate and other things like that. But you have to check with the medical terms and make sure that those are translated appropriately.
And as the former educational materials manager for the World Federation of Hemophilia, I will throw in a small plug that they also have quite a few resources in a whole variety of languages on their website that they do put through careful vetting with medical and scientific experts. But of course, those are global resources. They're not specific necessarily to the US context. I did want to maybe follow up a little bit. Let's say you are in a community somewhere and you're not too sure who to reach out to. Can they reach out to you to sort of say, hey, I'm looking for something in this language. Is there a chapter that might have it? Are you able to help them with that?
As a first step, yes, they can reach out to our team and we will connect them with the resources that they need, whether it's in-house with us, or if we have to connect them through chapter services, or possibly connect them with our med ed and med info team so that they have additional information that services those populations.
Great. Great. Thank you. And is there a site on the NBDF website where there's sort of more HEDI information available? This is a question that someone has posed.
Yes, Karina?
Yes, we have a dedicated tab within our website, and I will make sure to drop that link on the chat so that everyone can visit at their leisure when they can.
Great, super, thank you.
You're welcome.
Really neat information too about the E3 model, but I think this may be sort of new terminology for some people. So I was just wondering, could you maybe pick an example of an SDOH and maybe work it through the E3 model through NBDF? I know it's all the acronyms, but I figured I'd get them all through one question. But maybe it would be a good example of how this kind of all would work to take an SDOH and develop the E3 model for it within NBDF, and how would that work?
Okay. So in the E3 model, what it does is it takes the social determinant of health and walks you through how individuals can work on that determinant of health, how communities can work on that determinant of health, organizations, and then institutions. So that whatever level you identify with, you can say, I can do something about this within my capacity, within the resources that I have. I really feel like I can intervene here. So let's say social support. We know that having a good support system and having caregivers is really pertinent to various communities, not just the bleeding disorders community, but those with other chronic illnesses or rare diseases. And so at the individual level, what will happen is you'll be able to look at various interventions of evidence-based or promising practices, which are things that we know work at the community level. And with that, then an individual can look and say, well, I can start a support group. I know a couple of people, so I might not have family in my immediate vicinity to lean on because it's difficult to talk to some friends or some coworkers who don't understand my condition. And if I'm kind of far removed geographically from the HTC and I can't find community there, then I can create a community here. So it might not be bleeding disorders, but it might be others with chronic conditions or others who have to travel to go out of state. You can find them within faith-based organizations, or again, you can create your own and get a small space at the local Y or get a small space at a nonprofit, which they'll let you use their rooms and things like that on weekends or evenings for a small or for no fee at all. So that's what an individual can do for social support. At the community level, then of course you can have chapters that create these social support groups that meet at a time that's conducive to adults who work and adults who have responsibilities, right? So when they create these groups, then they provide resources for these people, or they have them to create their own resources, right? Because a lot of times organizations always don't get the picture. The lived experience experts have the answer, and sometimes they create the best resources in conjunction with others who know how to frame it and how to put it together. So that's something that can be done at the community level, is to embrace a support group or a peer group or a group of caregivers who understand the need to be able to pour into others, but also replenish yourself at the same time, right? And then at the organizational level, then it's for organizations like NORD, like NBDF, like Global Genes, like HFA, all of us to have various mechanisms where we encourage social support. We either are giving money to chapters to create these social support groups, or we have resources, which means literature or links where people can find social support groups. So things of that nature. And then at the institutional level, which is more so government, NIH, industry, things of that nature. Of course, industry has focus groups, but they're more so along the lines of, trying to find things out about clinical medicines, how you take your meds and things like that. But even in clinical trials, and you're meeting with your group, you still can formulate a community for support there. And then for NIH and others, then they understand the importance of social support and the importance of groupthink at times in the mental space of feeling well and in the space of feeling like have hope for the future, things of that nature, then they typically will fund these types of things. So that's what happens at the institutional level. And also there are various social support toolkits that are put out by the Office of Minority Health and Health Equity, the Office on Women's Health, things of that nature. So that's how the E3 works.
Thank you. That's great. That's nice and really comprehensive. And I think also really empowering, because it's the kind of thing that, as somebody said, it's a bit overwhelming to think about it. But when you break it down like that, it actually seems doable. It actually seems approachable. You mentioned that all of this, of course, exists within the context of policy, people, and politics. And somebody asked if you could maybe talk a bit about the inherent biases that we all have and how they can impact this work, and then maybe describe some ways to mitigate their influence.
Great question. Marissa or Karina, you want to take that before? I don't want to take up all the air in the room just by talking. Of course, I have an answer, but I want to be fair.
You start and I'll fill. How's that?
Okay. I'll punt it over to you. So in this space of kind of dealing with the political arena that we're all living in and navigating, we understand that when it comes to health equity, when it comes to specifically several of the populations that we've named as priority populations for the next 10 years, there are entities that either blatantly have bias and are openly biased, or they have what's called unconscious or implicit bias, which means there's been some type of interaction or some type of taught behavior that they've witnessed and they've carried into adulthood, whether or not they really believe the thing, but that's what they know. And culturally, that's what they've seen for the majority of their lives. So when you have that and you recognize, if you recognize that you have that bias, then the first thing is to be self-aware of your bias. And you don't have to walk around and say, I don't like people who wear purple nail polish. I just want to let everybody know. Oh, yeah. Hey, Fiona, I don't like people who wear purple nail polish. Karina, you don't have to admit it out loud to everyone. But when you are aware and you're cognizant and you have that recognition within yourself, then you're better able to self-regulate and say, I realize I'm going into a group or I'm going into a room where I'm working with others towards the best for a community or for my community. And I really need to self-regulate for how I'm addressing things and put this bias to the side and let it not influence how I interact, the types of answers that I give, and how open I am to communicating with others who don't look like me, didn't grow up like me, don't speak like me, don't eat what I eat, don't wear the shoes that I wear, all of these things, or don't believe like I believe. So that's if you're aware. If you are unaware and it becomes difficult to see because you don't know, you're just being you. You're the you that everybody loves, that everybody grew up with, and you were popular. Everybody likes you. Everybody's your friend. But at some point in time, you come up against something that points out you're not as open or diverse as you thought you were. And when that happens, then what has to happen is what's called cultural humility. You have to say, I recognize that I can only be competent in my culture, and that's the perspective that I put upon the world. Is that wrong? Absolutely, because everybody doesn't have the same lived experience. And so you should not expect you from others. So when you find that, then what you practice is, I don't know a lot. I'd like to learn more. I will be the first to admit, I'm a little bit uncomfortable. I've never had to work in this situation or what have you. And when you approach it with grace like that, when you approach it with an honesty and transparency like that, people will open up and they'll say, well, how can I help you? What materials do you need? What resources can I provide? Things of that nature. I encounter that almost on a weekly basis. And if the people felt comfortable, they would tell you, oh, I never feel bad when I ask Carrie something, or I tell her that I don't know something, or I'm a little bit uncomfortable, because it's my job, when you are respectful and when you are curious with questions and you are wanting to know and practicing cultural humility, it's my job to help you and assist you to be your best self so that we get the best results overall. And with that, I'm popping it over to Marissa.
I completely echo everything that Carrie just said, but I think it's very important as you start to recognize, for those who are either not self-aware or just kind of starting to become self-aware, it's really important to learn to question your first impressions. Stop and think about your reaction to a situation before you do it, before it happens. It's really important to to not ignore the differences between persons and situations, or excuse me, circumstances, to be curious about those, to be willing, again, as Carrie mentioned, to approach situations with grace in a place of compassion and learning rather than judgment and fear. And then though it can be difficult, you need to be able to start challenging your own negative assumptions and stereotypes. Think about why you're reacting to something, again, hopefully before you do it. But it's definitely a process that doesn't occur overnight, and it's something you'll have to continue to work at. And as Carrie mentioned, the cultural humility aspect is extremely, extremely important to learn how to be humble around others as they share those unique differences and are vulnerable with you about them. So that's all I wanted to add.
Super. Thank you very much for that. I really appreciate what you're saying about humility and curiosity. And I would venture that, in order for people to be comfortable to kind of express that vulnerability, there's probably quite a responsibility with leadership to create a context where that is a safe thing to do, where that is encouraged. Is there anything you can offer in terms of advice to leaders about how to foster an environment where that sort of humility is encouraged and that kind of vulnerability, is maybe rewarded, rather than sometimes it can be quite scary to make oneself vulnerable?
It can be having that kind of dual role myself, right, as being seen as a leader here, but also in this space where it's important for me to always be human, because as leaders, sometimes it's a little bit robotic, right? These are the things we do for leadership and management. These are the objectives. We have to hit these markers, all of those things. But as humans, as people with empathy and just who care, then it's important to create that space. So you always have to have someone who sits in a position, whether it's same title as mine, but just someone who sits in that position who is trustworthy, who's shown others in the organization that they're trustworthy, that they can keep their confidence, that they can come to them and ask, embarrassing questions, or just, really revealing things. Being able to accept that, not have judgment, and move people to want to do more. Once they reveal what it is they're curious about or what it is that they really want to work on and change, then the next step is, okay, let me give you some resources and let's work together, and then let's put it into action. So I'm not just going to give you a handout and say, oh yeah, go do this and do this training, and woo, you're equipped to deal with health equity, and you're competent now. That's not how we do it. We do it by leading, we do it by role modeling, so that in everything that they see me interacting with others, that they're seeing that kindness, they're seeing that vulnerability in certain aspects, that they're seeing that trustworthiness and that transparency. So it also requires you to do a little peeling, like the onion peel. You're peeling layers of yourself to be vulnerable in order to get that reciprocated to yourself. So I can't get Marissa to tell me who she really is and the things that she wants to work on if I don't tell her who I am first. So it's an earned trust. It's a space of sharing and transparency. And it's not really created overnight, but it's possible.
I think, sorry,
No,
I
go
think,
ahead.
yeah, I think to add to that, I think in terms of leadership is knowing who you work with, right? Their background, their lived experiences, and being respectful and mindful of those. I think in a sense with our HEDI champions, right? We train them and we give them the necessary resources and tools to be able to advocate and speak up should they be in a room where HEDI efforts are being disregarded or spoken down upon. So I think that's our goal with HEDI champions, we necessarily, right, myself, Marissa, and Carrie cannot be everywhere at the same time, right? So we want to empower our HEDI champions to help us out and be in rooms where we are not necessarily present and always speak on HEDI and having those HEDI lens on. So that's, I wanted to make a note of that as well.
Thank you, Karina.
Yeah, and you touch on something that I think is, it's been brought up again by one of the previous questions, but, just this, there's only so much, you can do. Capacity is somewhat limited, and you did talk about the importance of recognizing the capacity of the various stakeholders and doing this work within the capacity that is there. And within your strategic plan, your strategic objectives, you've set out priorities. Can you talk to us a little bit more about the process of setting priorities? Because these are all really urgent things to address. These are all populations that absolutely need, to advance towards health equity. How do you set priorities in a context like that?
So what typically happens is the priorities are going to look different, again, upon geographically where you are, what your resources are, and what you have. But whatever is pressing becomes priority, right? And you don't do it in a rushed type of state, which is why we didn't just say, let's do women, let's do people who speak Spanish, because we just could have pulled one population out of each of those 5 categories, right? But that's unfair because all of those populations don't live in the same vicinity or reside in the same area. So it's up to the individual chapters and communities to choose which of those bubble up to the top. So where are you seeing the most questions? Where are you seeing the most engagement? Let your engagement surveys drive you into the direction. Look at those outliers. So you do a survey of 110 people who showed up for your event, and you get all of this wonderful feedback, but you get those 2 little comments that say, I don't know if I'm coming back because I didn't see anybody who looks like myself. Those are the 2 comments you pay attention to. That's how you prioritize. You don't continue to build upon your strengths. So things that you've been doing well for 5 years, you scale them up so that they go to the next level, but you don't keep throwing money into those things. You have to build upon your areas of opportunity. I don't like the word weakness. Your areas of opportunity to then engage others and to strengthen the community that you're serving by making sure that elements aren't missing. So that's how you begin to prioritize. If you have translated most of your documents and you're done with Spanish, then you have to see what your next language is in your geographic area. We gave you a slew of recommendations, but we cannot tell you who lives in your particular area and what language needs to be prioritized. If you're in, the northeastern part of the US, your next thing to do might be Vietnamese. If you are in the South, then your next thing to do might be, Chinese. So you really have to take a look at what's in your area, the resources that you have, and then use your surveys and the feedback and the content. Use small focus groups. You can have 5 people, you can have 7 people or more, but use the feedback. You have to constantly engage to make sure that your finger is on the pulse of the communities that you're serving.
It continues to go back, right, to this idea of meeting people where they are at.
Yeah.
We have these 10, top 10 kind of strategic plans or ideas for folks to use. However, within that, we recognize that each bleeding disorders community, these smaller, more intimate ones, will vary person to person. And so this work, you have to, as Carrie said, have that continuous feedback loop, be evaluating your community members to stay up to date. Ultimately, right, we don't know what we don't know until you ask those questions, because if you start to prioritize, for example, translating into, you think that, oh, the next language on that list is Chinese, we should start doing that, but you don't survey your community, you could do all that work, spend all that money for nothing. So it always comes back to meeting community members where they are at, asking them those questions and working off of that feedback. We can set the stage, but within that, there has to be done that the work to tease out the specifics for each community.
I'll add to that. I think this is why the work of community roundtables and the feedback that we get from those
Absolutely.
is so important, right? Because we can say, oh, this is what we know, but nobody else knows better than the people living in the communities, right? So when we get kind of that resistance, it's like, wait, you are the experts here, and we need to hear from you. And this is why the E3 model is going to be an ever-evolving model, because the solutions are going to change, right? It's not going to be a stagnant model. And I wanted to make sure I made it a point to that, because I think that it's like undervalued, or how important the experience of the lived experience, like the experience of the experts are in terms of feeding into this community roundtables and the work that we do in terms of reaching the community and addressing the barriers, right? With the
Yes.
HEDI lens on.
Yep.
Yeah.
They should be at the forefront of all
For
of
sure.
this.
Absolutely.
Great. Yeah. So I guess a really, really prominent role there for our lived experience experts, and a lot of, coming back and constant consultation. That's a really great place to leave it, I think, because that really gives us a good idea of, kind of what can we do on a granular level, and what can we dream of big picture.
Yes.
I want to thank very much Karina and Carrie and Marissa for answering all of those questions. I know we really kind of gave you quite a few questions to deal with and to discuss in depth, but we really appreciate everything that you're teaching us today. And I did want to point out to our audience that we do have a link in the chat. That is the link that Karina provided for the NBDF HEDI page. So if you want to grab that, save that somewhere so that you can go back and explore it after the webinar. I'd like to thank Dr. Carrie Norris, Karina Lopez, and Marissa Melton from the NBDF HEDI team for sharing your expertise and your time with us this afternoon. And I'd like to thank each of our audience members for joining us. This recorded webinar will be available at hemophilia.org shortly after the webinar. Go to the NBDF website and under the events tab, select past events, and you'll find all of our archived webinars there. The Wednesday webinars will take a little break next week. As Karina mentioned, everyone will be busy with Washington Days, March 6th to 8th. And then we will be back the following week on the 13th of March with a webinar that you will not want to miss, an update on My Life, Our Future. Thank you very much for joining us this afternoon, and have an excellent couple of weeks.
Thank you,
everyone.
Thank you.